How's it going, guys? So this question is exceedingly high yield for both internal medicine and surgery for 2CK. Students frequently get this wrong, okay? And there's also some important points I want to make regarding these answer choices here. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram at Mehlman_medical, MEHL_medical. Link is down below. And find me on Telegram. Recently created a Telegram group and channel. The links are down below. Now let's start the question here, where we've got this 67-year-old man, and he has a 4-month history of abdo pain 1 to 2 hours after eating meals. This initially sounds like it could be duodenal ulcers, doesn't it? It's not, but doesn't it sound like that? Abdo pain 1 to 2 hours after meals? He has a 20-year history of type 2 diabetes mellitus and hypertension managed with multiple medications, and a CABG, coronary artery bypass grafting, performed 4 years ago. So what you need to know is that if you get a presentation where a patient has abdo pain 1 to 2 hours after meals, you say, is it, e.g., a 29-year-old dude from Indonesia where H. pylori is prevalent, and that sounds like duodenal ulcers, or is it a patient who's got many cardiovascular risk factors, such as diabetes, intermittent claudication, history of MI, CABG, okay, carotid stenosis? So if they give you a massive cardiovascular history in someone who gets belly pain 1 to 2 hours after meals, that's chronic mesenteric ischemia. That's atherosclerosis of the SMA or IMA. The same fucking way you can get atherosclerosis of your coronaries, leading to angina pectoris with exertion. Well, you can get angina of the bowel 1 to 2 hours after eating meals, as the bowel will require increased oxygen demand. So let's just move through our answers here. Choice A, 24-hour esophageal pH monitoring, wrong fucking answer. This is to diagnose Gerd, and this is to diagnose Gerd in patients who fail a trial of PPIs. So if you get, let's say, a 55-year-old guy and he's got symptoms of Gerd, he's got a nocturnal cough, or he's got burning sensation in the throat following meals, you do a trial of PPIs, okay? That's correct over H2 blockers if both are listed. I have seen H2 blockers as a correct answer on one of the surge forms, but PPIs weren't listed. The point is, if a patient fails a trial of PPIs for 2 weeks, which is normally what we do for suspected Gerd, then you do a 24-hour esophageal pH monitoring to confirm, is this in fact Gerd, okay? There's one question I've seen where that's actually the answer for 2CK. Choice B, angiography, is our correct answer. This will sometimes be listed as mesenteric angiography, where you are going to visualize that there is narrowing of the SMA/IMA, okay? That's going to confirm our diagnosis of chronic mesenteric ischemia. The discussion of acute mesenteric ischemia, very fucking lengthy, but I should just point out it's classically atrial fibrillation, okay? And it's nothing to do with atherosclerosis. You get a left atrial mural thrombus launching off to the SMA or IMA, and you get acute severe abdo pain, okay? And that's often requires laparotomy. I've seen laparotomy as an answer. Separate discussion. Choice C, ankle brachial indices, is wrong, but this is a very fucking high yield answer for peripheral vascular disease. So if they give you intermittent claudication, if they give you decreased peripheral pulses, then you're going to do ABIs, which is comparing the blood pressure in the ankles to that of the arm. And if the ratio is under 0.9, then that is the first step in diagnosing peripheral arterial disease, okay? And we go on to do a walking program after that. That's also a lengthy discussion. But even though this patient might have intermittent claudication, we don't see it here in the vignette, and it's not the focus. The focus is clearly the chronic mesenteric ischemia. Choice D, colonoscopy, is wrong answer, but not outrageous, okay? Because this is a correct answer for ischemic colitis, not to be confused with chronic mesenteric ischemia. So chronic mesenteric ischemia is this patient, okay? Belly pain 1 to 2 hours after eating meals with a significant cardiovascular history, atherosclerosis of the SMA or IMA. Ischemic colitis is going to be due to atherosclerosis. However, it causes, the presentation is going to be blood in the stool in a patient with a significant cardiovascular history due to ischemia of the watershed areas, the splenic flexure and the rectosigmoid junction. Colonoscopy is the answer to diagnose ischemic colitis, where we visualize the ischemic ulcers, the colonic ulcers. According to the literature, angiography has very limited benefit in terms of the diagnosis of ischemic colitis. Stool antigen and urea breath test are wrong fucking answers. These are for H. pylori, okay? So if you were to be fixated on, you say, well, I can see he's got a cardiovascular history, but The 1 to 2 hours after meals, the pain, this could just be H. pylori in someone who's got cardiovascular history. It's not, okay? So you need to be able to piece these elements of the presentation together and say, oh, okay, it's not H. pylori causing duodenal ulcers. This is just chronic mesenteric ischemia, okay? Which they're not going to force you to choose one or the other, stool antigen versus urea breath test for H. pylori. It would be one or the other listed, okay? You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.